Have you heard about FDA-approved Vyvgart Hytrulo, efgartigimod alpha, and hyaluronidase QVFC for subcutaneous injection? Visit VyvgartHCP.com to discover clinical trial data and explore patient profiles. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. I'm speaking with Avindra Nath from the NINDS and NIH. Podcast listeners will recognize Avi from our prior podcasts on the neurologic implications of the COVID-19 pandemic, as well as more recently my interview with Avi following his acceptance of the Ted Burns Humanism in Neurology Award. Avi is an expert on neurovirology, from HIV to COVID-19 to Zika to a number of other viral infections affecting the nervous system. Today, we invite Avi on the podcast, asking that he teach us about the current state of our knowledge on post-infectious myalgic encephalomyelitis, formerly known to many as chronic fatigue syndrome. Avi, welcome back to the podcast.
Thank you so much, Jeff. It's a pleasure.
So, Avi, let's set the table a bit here with regards to nomenclature for the syndrome we're about to talk more about. I think many are probably more familiar with the term chronic fatigue syndrome, but my understanding is that the name for this disorder that's more appropriate is myalgic encephalomyelitis. And today we're more specifically going to be talking about this syndrome as a post-infectious entity. Do I have that right? Anything you want to clarify in terms of the words we should be using when we're talking about this syndrome?
The terminology is quite confusing, both to patients and to physicians. Patients don't like the term fatigue because they claim that they're not fatigued. What they really have is this malaise that is the problem. And physicians think that the term encephalomyelitis is not entirely correct because there's no evidence of myelitis or inflammation within the brain. So we're kind of stuck in limbo, not knowing exactly what to call the syndrome. I think more and more people are using the term post-infection syndromes because what we're beginning to realize is that there are a lot of these syndromes out there, like long COVID, post-Lyme disease, post-Ebola syndrome, Gulf War illness. They all have very similar symptomatology and quite likely pretty similar underlying pathophysiology as well. The only major difference being is that the initiating factor could be different. So I think over a period of time, we'll probably lump them all under the umbrella of post-infection syndrome.
And so I'll use the term myalgic encephalomyelitis, but I think that's helpful to know that consensus on how we should be naming these post-infectious syndromes is not yet there. But given all of that, can you teach us a little bit about that clinical syndrome that you just alluded to of myalgic encephalomyelitis? What would you recommend that our listeners pay attention to and keep in mind when it comes to recognizing and diagnosing the syndrome? Are there key history features or key exam features or other clinical findings that you would recommend that listeners tune in for or pay attention to?
Most of these patients will describe a triggering event, and most often, though not always, it is an infection. They'll have a pretty significant infection. It could be a respiratory or GI infection, and those are really the two most common ones. They may recover from it, and then over a period of time complain that, okay, now they're developing new symptoms, or they had symptoms during the phase of the infection that they haven't totally recovered from, and they tend to linger on. And those symptoms are often described as post-exertional malaise. And what they mean by is that if they exert themselves, either physically or cognitively, and it may not even start immediately and may take a few hours or even a day afterwards, they then realize that, they're just totally exhausted. And the exhaustion can be mental and physical. And so they think that they pay a price for that exertion that they have to do. Yeah? And they may use a lot of different English terms to describe that, but in the umbrella term actually is malaise. And that is a prominent symptom. The second thing is that most often they will also develop some autonomic symptoms also. So some sort of dysautonomia is quite common. And they may complain of dizziness when they stand up, or, palpitations or tachycardia that they can't really control. And they may even describe it as a panic type symptom. And then they may complain of cognitive difficulties. Now, whether the cognition is actually related to the dysautonomia is not entirely clear, but it could very well be independent of that. And then they may develop some pain-like symptoms as well. They feel like the flu-like symptoms just never quite go away.
So I think that's really helpful. And it sounds like some of the key features to pay attention to are, one, the triggering event, typically an infection, either respiratory or GI, but following that event, either a lack of full resolution of symptoms, or specifically, as you mentioned, a malaise that could be triggered by physical exertion or cognitive exertion. I think that latter point about cognitive exertion is really important to pay attention to. And then couple that with some flu-like symptoms or some lingering pain after the triggering event, as well as some autonomic symptoms, tachycardia, or other autonomic variability that wasn't present before the infection. Do I have that constellation of symptoms and signs reasonably dialed in?
Some patients may develop a full-blown POTS as well.
Okay, so meeting criteria for other autonomic symptoms as well is something to keep an eye out for. And so in looking for the literature and in speaking with colleagues about this disease, I think you've touched on it a little bit, that there is stigma surrounding this condition. And as I was preparing for this interview, I came across a JAMA medical news article by Quinn Eastman about your work that said myalgic encephalomyelitis is a condition that has had a, quote, legitimacy deficit, unquote, for decades. I think many may have associated this condition with functional neurologic disorder or asserted that this was a somatization disorder. So what can you teach us about the history of this disorder? And importantly, maybe give us a sneak peek of what you and your colleagues are learning about this disorder that may move myalgic encephalomyelitis away from this legitimacy deficit that's been given before, and to maybe work to destigmatize it.
If you look at the history of neurology, unfortunately, we've had a lot of diseases that we've wondered whether they are somatization type disorders, only to realize that there's a biological basis for it, right? And so even seizures at one point in time were considered hysteria. Dystonia was considered a functional disorder. When neurologists don't have hard findings on their exam and the history doesn't quite fit into the way they understand the functioning of the nervous system, they start to wonder if patients are just exaggerating their symptoms, or maybe they're just seeking attention. And so we jump to those conclusions, I think, a bit too fast. And I think the same thing has happened with these patients as well. And really, if you sit and talk to them and listen to them, their stories are actually quite convincing. It's just that we don't really find anything on exam, and we start wondering about other possibilities. The research that is now coming on, not just from our group, but from others as well, is starting to point to the fact that there is a biological basis for it. And I think once we have a diagnostic marker or a disease-altering medication, then all these things will go away very quickly. And even multiple sclerosis is another example, whereby a lot of patients were thought to be functional before we had any kind of treatment. They wouldn't even show up in a doctor's office because they knew that we wouldn't really do much for them. And all of a sudden we have MRI scans and all kinds of disease-modifying therapies, and now it's not a concern any longer. We can diagnose and treat it appropriately. So I think we are in those early phases with these illnesses, although they are a little bit harder to diagnose and treat. But I think soon we will recognize this as a true biological illness that requires intervention from neurologists.
So let's drill down into that a little bit more and focus on myalgic encephalomyelitis as this post-infectious syndrome, this post-infectious phenomenon that you talked about. And so you and your collaborators, as well as other researchers, have been looking at patients with this clinical syndrome and looking at the pathophysiology of this disease from a post-infectious immunological perspective. And so can you give us some examples, either from your research or that's available in the field, as to what are we learning about the immunological processes that might be underlying the etiology and the pathophysiology of the syndrome that we've been talking about?
In our study, we did a very, very detailed immunological workup on them, but that was not the only thing we did. I think people have reported on some immune defects in these patients, but not as detailed as we did, because we looked at the blood, we looked at spinal fluid, we looked at cytokines, the various types of cells that were present there. We did metabolomics, we did every omics you can think of, and including the microbiome. We did transcranial magnetic stimulation on them. We did, all kinds of neuroimaging, functional MRI, structural MRI, very detailed neurotransmitter and autonomic testing on each of these patients. Looked at effects of exercise on them. The advantage of doing a very detailed phenotyping study is that now, if you do find some immune abnormalities or what have you, you can now try to correlate it with all these other physiological parameters that nobody's been able to do before. We even looked at, we did muscle biopsies on them and looked at mitochondrial function in many different ways. We put them in a metabolic chamber and looked at their caloric intake and output, sleep studies and the whole gamut. So that provides us a very rich data set. And now we've also made all that data available on the internet to anybody who wants to analyze and reanalyze all of that and derive their own conclusions or take their own data and try to see how it matches with what we have. So when we did that, I think it was very clear to us that these patients have a defect. I think their primary defect is in B cells. So they don't switch from IgM to IgG very easily. And when you don't see that switch taking place, you need the B cells in order to get the T cells mature to respond to an antigen. So if the T cells are now unable to respond to an antigen, they will get exhausted. So you have this now situation of abnormal B cells with exhausted T cells. And when those two happen, what happens is that your innate immune responses get triggered. And so then you get all these cytokine production, macrophage activation, and that produces that sickness type syndrome. And so I think that those are really the cascade of events immunologically that I think are leading to the syndrome that we see.
I want to summarize that because I think that's helpful. And I am not a neuroimmunologist, and I think I understand what you're saying here, which is progress. But by that difficulty with the B cell processes where there should be a transition from an IgM to an IgG with subsequent maturation of T cells, if that's not happening, then with the activation of the innate immune system, we get the cytokines that get released that make us feel the malaise and more chronic sickness, for lack of a better term. But that chronic malaise and that poor response to exertion is what patients are developing a syndrome of, but you're starting to describe what's going on with the immune response after these infections that is explaining it. Am I there?
The innate immune response is a very primitive immune response. So if you look at animal systems that do not have cellular immune responses, what they have really is the innate immune response. But it's not a very precise immune response. So when the cellular immune response fails, the innate immune response is all you have, and to fight whatever the agent might be. And that produces a lot of bystander damage. And that's why the activation of the innate immune response is actually detrimental.
Got it. And so one of the other things you talked about in your paper where you did this deep phenotyping of patients with post-infectious myalgic encephalomyelitis is you talked about a phenomenon called effort preference and its relationship to certain brain networks. And so can you teach us a little bit about what is this phenomenon of effort preference and maybe some of these brain networks that are involved, especially in the context of some of these immunological mechanisms that you're just talking about?
Our brain actually makes decisions constantly about every little act that you have to do, right? We don't always think about every movement we make. If you had to think about it, we actually wouldn't be able to function. So our body makes very automatic decisions. And, if you have to pick something up, you have to jump over something, or you have to step over something, you do it subconsciously because your body makes all kinds of calculations and decides, okay, this is the amount of effort that I need to put in order to accomplish whatever task you're trying to do. And your body also knows that, let's say you get close to a cliff, okay? And your body immediately knows that, okay, this is a danger sign here. I can fall off the cliff. So even without you consciously thinking, your heart rate will go up. You'll get a little knot in your stomach and you'll know to back off. But there's also a conscious element to it because you can see the cliff and you say, well, I don't want to go close to it, right? And so there's a subconscious and a conscious effort there. And I think that's what these patients are also doing. So they know that from prior experiences, and their body has learned that if you exert too much, whatever it is, you're going to pay for it, right? So now when we put a easy task and a hard task in front of them, they will subconsciously go for the easy task because they know what the consequences are going to be. It's not like they cannot do it, but they know what the consequences might be. And so that is what we term effort preference here.
So it's almost a recalibration of that subconscious effort or the control of all the motor movements that we have to do without thinking about. And in these patients who have this post-exertional fatigue and malaise, there's almost a recalibration of that effort. Is that right?
That's absolutely correct.
And so we've learned about the altered immunology in patients with myalgic encephalomyelitis. We just finished talking about effort preference and the sort of recalibration that's happening in these patients. And so let's try to speculate a little bit and look forward. But given what you've learned about the activation of the immune system or the lack of normal response to infections, what might that knowledge hold with regards to developing treatments down the road or interventions for patients who are struggling with this syndrome, with this disorder?
So the underlying hypothesis is that if you have a defect in the immune system, what you're unable to do is really clear the antigen. So what I'm not saying is that there's not, let's say it's a viral infection. I'm not saying that they have fully replicating virus still persisting in them. What it is that there could be bits and pieces of them that are still hanging around and they haven't been able to clear them, right? And I said that there's T-cell exhaustion. That makes me think that they're getting exhausted because they're trying to fight against something, but they're just are unable to clear it. So if that's the case, then one possibility would be that you try to reverse the T-cell exhaustion. And so one could consider doing a clinical trial with checkpoint inhibitors. Now, I want to say clinical trial is important because these kinds of drugs have potential side effects. And so one shouldn't really use them unless you really do it in the context of a clinical trial where you can monitor a lot of things very carefully. But that's one possibility. The second possibility is that you can suppress the innate immune activation if you stratify your patients accordingly. And there you have multiple choices. So depending on the cytokine profile that is elevated, you can block TNF, IL-1, or IL-6. And we have various kinds of medications available to do that. One can also non-specifically block cytokine production. And so we have various types of medications available for that as well. The patients are very interested in trying to see if you can use poly-IC, for example, and blocking things. I think that also makes sense. If it's some kind of a viral infection, you can do non-specific blocking of your toll-like receptors and see if that actually helps. So there are multiple different ways in which one can use immune modulatory drugs to see if one can impact the course of this disease. But at this juncture, I think we should do it in the context of a clinical trial.
Yeah, I think that's important. And you mentioned a number of different therapies that are available for various disorders out there, but haven't been studied in this clinical context. And I think that caveat, is important to reiterate that we have to be methodical and rigorous as we're studying possible treatments here. And so knowing that clinical trials and further research is needed, but if we bring it back to bedside clinical neurology, think about our listeners who are going to encounter patients with this disorder. And given the stigma that we discussed earlier, I think they may find that they're seeing a patient who maybe has seen multiple different physicians before they finally land with the neurologist or land wherever they land. And so for the neurologists who are listening, what is our role in the diagnosis and perhaps more importantly in the management of this disorder? What would you want the listening clinical neurologist to know about how they can help patients who come to see them with a concern about myalgic encephalomyelitis or who carry a diagnosis of a post-infectious myalgic encephalomyelitis?
Most neurologists are pretty astute in suspecting the diagnosis, but there are a number of things they can do. Number one, I think, is to really believe your patient. I think it frustrates the patients immensely when we discount their symptoms, and then it just results in doctor shopping. And then they get very frustrated, and either they just stop seeing anybody or they just keep going from one doctor to another. So I think the first thing is really to reassure them that, yes, we do believe in their symptoms. The second thing is to make sure there isn't some underlying cause. And I'll tell you, in our study, we brought in these patients who were referred by experts who see a lot of ME/CFS patients. And when we studied them intensively, we actually found some of them had underlying causes or diseases that had been missed. And there were a wide variety of them. We found from Parkinson's to cancer to myositis. Now, we did a very extensive workup. I don't suggest that every patient you see should get $1 million workup, but what you should do is at least follow them along, because if there is an underlying disease, it will eventually declare itself. I think that's the first thing to do. The second thing is there's a lot of symptomatic treatment that you can provide to these patients that can really help them tremendously. So if there are mood disorders that can be treated, there's cognitive disorders, they can be put in cognitive rehab. And, autonomic symptoms can be treated quite adequately. And pain syndromes can be treated. So I think there's a lot that can be done for these patients, and neurologists are really the best subspecialty to manage these patients.
Certainly, there's lots of examples of conditions that we may not alter the disease progression or modify the disease, but we are very good in lots of other clinical contexts of helping patients address their symptoms, be they cognitive, autonomic, pain-related, like you just said, and couple that with trust and with patients and following patients over time to make sure that nothing else emerges that could explain their symptoms. But Avi, thank you as always for these lessons.
Well, thank you for having me on the podcast.
I've been speaking with Avindra Nath from the NINDS and NIH about his work and his expertise on the topic of post-infectious myalgic encephalomyelitis. For those who want to read more, I would encourage you to check out the article that was published in Nature Communications in February by Avi and his colleagues titled Deep Phenotyping of Post-infectious Myalgic Encephalomyelitis / Chronic Fatigue Syndrome to learn more about some of the biological and immunological biomarkers of this disorder as well as the associated phenotype. Thanks for listening to the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.